This is Vaccine Real Talk, where we're going to talk about the achievement of the COVID-19 vaccines and the questions that are being raised about them and how we honor the concerns that people have about vaccination at this very complicated moment in our public health history, while making sure that everyone gets the protection that they need and deserve. I'm Maryn McKenna. I'm a journalist and author and a part-time faculty member at Emory. We're very glad to have Emory support for this. And I'm going to let my four panelists introduce themselves, and then we're going to engage in conversation for most of this hour among the four of us, five of us, me and the four of them, and then we'll welcome your questions as well. So I'm just going to tell you who the individual people are, though you can see your names, and then we're going to go kind of in a round robin and let everyone describe their work and what they do. So I have no idea what things look like from your point of view, but from my point of view on my screen, Dr. Risa, Dr. Breanna Lathrop, Dr. Colleen Kraft, and Ms. Brittaney Bethea of Georgia State Good Sam Health Center, Emory, and the Morehouse School of Medicine. So I guess, shall we just go in that order? Let's start with Dr. Palm. Tell us your position and what it is that your research is about.
Right. So I'm a professor of urban studies at Georgia State University, and my PhD is in geography, but I'm terribly interested in science communication. And so we've been especially looking at issues of understanding climate change and the acceptance of climate change mitigation. And that is very much related to the ideas of the acceptance of the COVID vaccine. So that's how I became interested in this.
Fantastic, thanks. Dr. Lathrop, how about you?
Thank you for having me. I am the Chief Operating Officer at Good Samaritan Health Center. I'm also a nurse practitioner and see patients clinically about half of my time at the clinic. And we are currently a Department of Public Health vaccine site, and I also do some work nationally with free and charitable clinics around the issues of vaccine distribution and vaccine hesitancy within the communities that we serve.
And Dr. Kraft.
Hi, my name is Colleen Kraft, and I'm an infectious disease physician and clinical microbiologist at Emory Hospital. I'm also recently became the Associate Chief Medical Officer, so been really involved with COVID from a hospital perspective and from a clinical and testing perspective, but have spent a lot of time listening to our staff in the hospital. It's been a real joy of mine to listen and hear the concerns that have been around vaccines.
Finally, Ms. Bethea, tell us about your work at Morehouse School of Medicine.
Hi, my name is Brittaney Bethea, and I'm the Director of Communications and Dissemination at Morehouse School of Medicine. And I lead the National COVID-19 Resiliency Network's communication strategy, which is funded by the U.S. Department of Health and Human Services, Office of Minority Health. Primarily, I focus on integrating principles of traditional marketing into social marketing programs, as well as health comm programs.
Thank you all so much for introducing yourselves. I'm really fascinated by the work that all of you are doing. So I want to ask you a couple of questions each about how what you have learned about attitudes toward the pandemic and toward vaccination in the work you've been doing. So Dr. Kraft, I think I'll start with you. From engaging as a clinician, and with patients, and also in talking to the staff, what attitudes about vaccination are you hearing, and what concerns?
Yeah, so I think, there's a wide range, and I think that's something that I wasn't entirely prepared for, but completely understood once we started talking about it. I think there is definitely a group of people in terms of when you talk about attitude that were rushing towards as soon as they could get the vaccine, they wanted to be first in line. And then there were a lot of people that wanted to wait to just see what happened. And I think that was something that we talked a lot about sort of like if we're in the middle of this forest fire, we don't want to wait to grab our bucket of water. We want to put water on the fire, and us doing our own part, getting vaccinated as part of that solution. But a lot of the things had to do with, side effects. So that's been a really interesting journey, talking about that side effects for a good vaccine is a good thing. Obviously concerns about fertility, and would they test positive for the virus, and just long-term effects. And so when we actually broke down and talked about the mechanism of the vaccine, that became a really great dialogue. And most of the time when I spoke to different groups, they were answering their own questions once they learned about the mechanism of the vaccine. So it's been a really great learning, and trying to support people wherever they are, to be able to understand and listen and have a relationship in order to move them along in their thinking. So it's been a great time.
Dr. Palm, you have done research on how political identity affects people's attitudes toward vaccination. Could you talk about that a bit?
Yeah, we've done some survey research on what it is that would make people more or less positive about taking the vaccine. And what we found was that there are three issues. One is that people have to see that it's safe. They have to believe that it's safe. They have to believe that it's effective. But the most important one was that everyone else is doing it. Everyone else is doing it. And so then the question, the answer to your question about the political issue is, who is everyone else? What are we talking about with everyone else? So what we are seeing is a very, very strong distinction in political orientation about everyone else. Very consistent findings that Republicans, and especially male Republicans, are likely to say that they are not going to take the vaccine, even if it is available to them. And that's in contrast to independents, and very much in contrast to Democrats. And we can go into some of the reasons for that, but it seems to be very much a partisan issue.
That is really interesting. It had not occurred to me that vaccination would be, attitudes would be stratified by gender. Ms. Bethea, that you started to talk about the National COVID-19 Resiliency Network. What did that network arise out of, and how does it intersect with concerns that the Black and African American community would have about vaccination? Can you talk about that?
Absolutely, sure. So this actually was developed out of a cooperative agreement with the Office of Minority Health to ultimately build a strategic and structured network of organizations that really span across public health agencies at the federal level, state and local public health organizations, as well as grassroots community organizations, hospital systems, even faith-based organizations, so that there was a coordinated effort to centralize messaging and then actively disseminate it rapidly. And so ultimately what we have done is built a network of over 300 organizations who are a lot of times volunteering to disseminate the messages that we have created, adapted, and then ultimately we're also translating into multiple languages for a wide range of racial and ethnic groups. So, we are focused really, closely on the African American community, because that is the community that we have the expertise with. But because of the expertise of all the organizations in the network, we're actually conducting interviews as well as focus groups in the community with the Hispanic population, as well as Asian Americans, as well as Hawaiians and other Pacific Islanders, and Native Indians as well. So it's not just African Americans that have that unique cultural need. And so what we're doing is making sure that we gather those insights from an evidence-based perspective to then inform what messages and materials that they need that are specific to their cultural lens.
So I really want to hear more about how messaging needs to be culturally specific, but let me just go to Dr. Lathrop for a minute, and then we're going to get more into the question of how vaccine messaging needs to be stratified. Dr. Lathrop, Good Samaritan Health Center serves the underserved, including the homeless, I believe. So could you talk about what the particular concerns are for getting vaccine information and vaccine to people who are medically underserved, and what your challenges are?
Absolutely. I think it's important that there's kind of separate issues that I've actually, in conversations with a lot of my patients, been surprised in a good sense by how much interest there is in getting vaccinated. But there's so many barriers in terms of how do I register? Where should I go? How do I get there? Will I have to take off work the next day? So I think that when we talk about why are people getting vaccinated, it's not just a question of is there this hesitancy or fear, but also are there so many barriers that make it difficult to approach something that already feels new and challenging. And so I have both the questions, the most common question among my patient population is about safety, actually. And I think that's really valid because a lot of my patients have had very negative experiences in the healthcare system and have felt not listened to, have been left out of clinical trials for generations. So there's these fears are very grounded, but it's not all fear. It's also access and how do I get a vaccine at a location where I feel comfortable, and how do I navigate that system?
That's really interesting. Before we go any further, I can see in our sort of roll at the bottom that we do have people listening. Thank you very much for coming. You can put your questions at any point into the Q&A column of the Zoom interface, and we will pick them up when we open things up to Q&A. You don't have to wait for me to announce that it's time for the audience Q&A. If anything occurs to you as we're talking, please just put it in there and we will get to it, I promise. So Brittaney, let me go back to you. I really would like to hear more about how messaging has to be tuned to the concerns, present concerns, historical concerns of different communities, and how you develop that and how you test it to make sure that it works.
Absolutely. So, well, ultimately, what we're applying is a framework called community-based prevention marketing. And community-based prevention marketing is ultimately a process by which you engage community members to understand from their perspective what are the most critical components to addressing their experiences for whatever topical focus you have. So, for example, with the pandemic, we understand that many individuals have lost jobs. We understand that many individuals were facing chronic diseases prior to the pandemic. We understand that some people are really laser focused on so many other issues that they were living with day to day prior to the pandemic. And we have to understand, how does a community member or a cultural group rank like an activity like getting tested or taking the vaccine in regards to all those other social needs or health needs. And so, depending on the cultural group, we have to understand essentially those barriers that we were just referencing that would keep someone from participating in those behaviors that we're promoting. And then also, what are the facilitators? So we think about, the messaging voice, or the source of messaging, or, those trusted individuals and communities who already have existing relationships and influence. And so a lot of our work is identifying who those individuals or types of individuals are. So this might be someone at a barbershop, or this might be a faith-based organization leader, or perhaps it is a community health worker. So we basically research all of those different preferences and current knowledge bases, what barriers exist in those facilitators for each cultural group. And then from there, we're able to collaborate with, basically content developers to develop a content strategy and decide how we might frame a particular message based on the insights that we receive, as well as understanding what are the preferences as it relates to the format of information. We've seen so much information on TV and radio, infographics, motion graphic videos. People have preferences. And so understanding what are the differences across the different groups so that it isn't a one size fits all approach.
So the community contacts or nodes or facilitators that you're talking about, they might well be different for different groups. It wouldn't necessarily be the same for African Americans as for Latinx, as for Asian Americans and Pacific Islanders. And you have to work to identify those.
Exactly. And even when it comes to dissemination planning, we think a lot about, top media outlets, for example. But those top media outlets differ depending on the cultural group. So, you might focus in on Telemundo for Hispanic populations, but you might focus in on BET for African American. And it's not that you don't integrate a strategy for the general population, but you really hone in on the specific preferences of that group so that you tailor your communication strategy and also target individual groups as well as organizations that already engage with that community. And that really speaks to, like I mentioned before, the types of organizations that we're partnered with.
Mhm.
So, we are partnered with Unidose, 100 Black Men, the Links of the Southeast region. We're partnered with Wellstar. And a lot of these organizations have deeply rooted, trusted relationships with communities already. And so we leverage those relationships and respect those relationships as we basically implement our communications campaign.
So I think you mentioned when you began speaking, because Breanna had mentioned it as well, that there's a question of access or a question of barriers. Do you mean barriers in the sense of more sort of psychological and historic barriers, or are they physical barriers, like people don't have a car and we can't get them to a vaccination center on public transit?
Yeah, absolutely. I mean, in social marketing, we call these the cost of engaging in the behavior that we're trying to promote. And so it can be psychosocial barriers. So in terms of what I personally believe or what I think in regards to the safety of the vaccine, it can be a tangible barrier, like I don't have transportation to get to the nearest testing site or vaccine facility. It can be barriers in regards to cultural ideals or practices. So it really varies and depends on which particular cultural group we're focused on.
So Breanna, for your patient population, are the barriers, are they physical barriers? Are people can't access transit? Literally, people may not be housed. They don't have a place to leave their stuff. What sort of things do you hear?
All of the above. I'll give you an example is that most vaccine scheduling requires internet access and uses online portal systems. And so if you don't have a home computer or you're trying to do it on a smartphone or internet access isn't consistent, or just by age, you're not comfortable with online scheduling systems, oftentimes you're left out of a lot of opportunity to schedule. So one choice we made at the clinic is we do all of our vaccine scheduling by a phone line, and we've created a scripted volunteer base of 80 people so that everyone calling actually speaks with a live person that walks them through how to schedule, why you need 2 appointments, schedules both appointments while they're on the phone. And we've found that that was really necessary to make sure that our goal as being a vaccine site was that we were going to do everything we could to address the known barriers within our community and patient population. So that's one example. Certainly, we have a large population of people that are experiencing homelessness, and there, a big issue is that you've got to have these vaccines scheduled. For us, we have Moderna exactly 4 weeks apart. And for my purposes, when I'm defrosting vaccinations, I've got to land on exactly an interval of 10 every day. So it means if there's a population that normally, for example, comes to our walk-in clinic, it's designed to be accessible when they need it and flexible when they can't get there. Vaccine rollout doesn't really work in that scenario. So it's also, for many of our patients that we have programming and ways of doing medicine that were designed to meet their needs, that we're working on how can we creatively allow our vaccine process to look as much like our normal healthcare access as we can. Some of it we can be creative about. Some of it we can do things like we're having a phone and a live person conversation. Some of it, like having a strict schedule and defrosting bottles in the right amount of time, is out of our control. And so I think that, we as organizations and as vaccine sites, that's the kind of questions we need to ask, is say, what do we know about our patients in our community, and how do we adapt this process the best that we can to meet people's needs? Because if people are already feeling and thinking and wondering, what I've gotten a lot of conversations is when I bring up the vaccine, before I'm asked about safety or anything, I'm asked, are you giving it here? And when I say yes, I can help you schedule it here, all of a sudden people are willing to ask me questions they maybe weren't ready to, or they're like, oh, well, maybe I am interested. If I can come to a place I trust, if I can come to a place I already know how to get there, that it creates this sense of maybe this is approachable when it had seemed kind of this overwhelming process for multiple reasons.
That's really fascinating that the first thing is the physical thing. Can I get this? I'm not going to waste my cognitive, I'm going to engage with the cognitive burden of thinking through all the possibilities of this if I don't know if it's immediately available to me. So Colleen, as a hospital-based person, what does this discussion of barriers sound like to you?
I just wish I could download everything in Brittany's brain and use it everywhere I go, because it makes me feel like I'm so much of a rookie as I'm trying to understand and meet people where they are. And so I'm really focusing on like personal relationships and being sort of a listener and a confidant and a non-judgmental person. And that's sort of like my skill set in terms of trying to support people in vaccine. And I've been at Emory in my location for almost 20 years. And so there is some level of long-term relationships and long-term, hopefully, just the reputation that I'm a listener is perpetuated. But I just wish that I think so much of what you said is like an objective way to describe like what I've found out very anecdotally. We ended up, there were so many people I figured out don't have computers. And so if they've switched their jobs to be our screeners, so they're taking temperatures at the door, they may not be on a computer like they would have been if they were a clerk in a clinic. And so, that was a barrier. And then I also, another barrier was transportation. And so we started having things at the hospital and still have, instead of going to a centralized location, which I think, like Breanna said, had some challenges, because I think there was the possibility of more vaccine waste if you were putting it in a less, we have sort of this huge machine that is running at Northlake. And, when you're going to give 500 to 1,000 a day, it's a different level of planning. However, you're more likely to use up every single dose. And so I think it's just been, some of these things have been more objectively stated by the expert in the field.
So Risa, before we move off this topic of barriers and access, I want to be sure to ask you, Brittaney was describing how important it is to find people who can speak to groups or communities in the language that they already possess with their cultural concerns. How does that intersect with the work that you are doing about openness to vaccination or not based on political identity?
So I think there are a lot of the same lessons. And by the way, Colleen, your personal relationships with people are really very important. And Brittaney, what you're talking about focusing the message on particular groups, all of that is tremendously important. So I think that's exactly what the research would show. It's strange to talk about partisan audiences, but some of the numbers are just stunning. A recent CNN poll said that 57% of Republican men say they will not take the vaccine, 57%. And there was a Marist poll that found that of those people who voted for former President Trump, 47% of them will not take the vaccine. So we are talking very much about a very important political orientation. As far as this is concerned, there was I think a very interesting report on a focus group, a couple of hour focus group with a group of Republicans to find out what was in their mind, what is it that is affecting their not willingness to take the vaccine. And they concluded that they're not particularly impressed with stars or celebrities. It's not that a star saying I will do it or a celebrity saying I will do it, that's not impressive. What they felt they wanted was all of the facts. Don't hold anything back from us. All of the facts. What are all of the risks? And the argument that the long-term effects of COVID-19 are clearly worse than the long-term effects of the vaccine. That was a convincing argument, but it's very complicated, and it's as Brittaney is saying, it's organizing that message for the listeners and for what their assumptions are. It's really that it's the same message whether we're talking about a political audience or various cultural groups.
So now I just need to follow up on this. Did you find that did women in your polling have a different point of view about what would make them more open or less hesitant? Were there different factors for them than there were for men?
Than men. And we didn't go into enough to find out what women were thinking or men were thinking. On the other hand, there is so much that has been done in social psychology, looking at the idea that men don't feel themselves as much at risk as women. Women are more sensitive to what might be out there at risk and what they need to do for their families and communities. And so this would certainly go along with that.
So you were talking about what the levers that would move, that would affect people's hesitancy to vaccination, wherever that hesitancy starts. I'm really curious for the other three of you, for whatever potential patients you engage with, when you hear people being uncertain about the vaccine, what are the things that most would change their minds? Breanna, you talked about literally it's as simple as in guaranteeing people access.
I'm so sorry. I lost sound there for a minute. Can you all still hear me?
Yes. You're
Okay,
still with
great.
us.
I lost the
So-
very end of what you said.
you took where I was asking about for all the different communities and groups that all of you are engaging with. I'm really curious if the levers that move people off being concerned about the vaccine or uncertain about it, how much they differ. And so I was thinking, you talked about how guaranteed access to the shot, uncomplicated access, sounds like the most important thing for your patient population. But I'm wondering if there's anything else for people who are uncertain or hesitant, who've had negative interactions in the past with the government, since this is a government program. Are there things you've found you can say that increase their comfort?
So after access, I get asked a lot about the safety of the vaccine, and I really enjoy the opportunity. I liked what Colleen said about relationships, is to just say, like, that's a great question. Like, you should absolutely be worried about the safety of something that's going into your body, and you have every right to ask those questions. And I've actually talked to lots of patients about, like, how do clinical trials work in the US, and like what makes something get to market faster than something else. I think that it's not necessarily always just government mistrust, as this happens so fast. Like, how did we just hear about COVID-19 a year ago and now we have a vaccine? Like, I thought things take a long time to figure out. This seems like we skipped some steps. And so talking about, like, how do you fill a clinical trial? Like, what is this research based on? You know, COVID-19 not being the first coronavirus. And I found that people really engage. They want that information. And I think sometimes I have made the mistake of just pushing, like, let's do it. How many people can get vaccinated? But that taking that step back and really making and creating spaces for those kind of conversations and that sharing of information is really essential to helping people make, like, an informed decision. I also get asked a lot about what if I'm eligible and family members aren't, which I think is a really cool question. Like, is there any chance that I could get vaccinated and then give it to somebody because the vaccine's inside of me? Or what if I get the vaccine and therefore I get a more mild case and I don't know to quarantine and I spread it to my family? I think these are fabulous questions. And so talking about, so what does vaccine look like? You know, these are folks that aren't asking, what does vaccine mean just for me, but how does that interact with the people around me that I love? And so talking about vaccination as a tool for protecting your community and your family, and what are the risks and benefits that vaccines have in that regard, has been also a really cool conversation with patients.
Did you ever imagine that running a community health center, you'd be talking about clinical trial structure this much?
There are a lot of things in the past 12 months that I never imagined I would be talking about with patients or doing. But I think it's been, I think the big picture for me is that we can take this as a learning experience. And I think that as healthcare, it's shaken our world. And that's a good thing, that there are a lot of deep inequities ingrained in the work we do, and something that brings those to light and helps us as individual providers kind of check our biases and figure out what we need to do differently, but also helps us check our systems and say, hey, we changed everything to deal with a pandemic. Why can't we change everything to eliminate health disparities? So a bigger discussion, but I think that, aside from all the hurt and pain and destruction the pandemic has done, I hope that the kind of conversations we've had in order to address this pandemic get translated into addressing other disparities that have been long too just ingrained in our systems.
Brittaney, I see you nodding.
Yes, absolutely. It's reminding me of some of the engagement opportunities that we've been providing organizations. So we stood up community coalitions that are regionally organized so that physicians can collaborate with strategic communicators, or public health administrators can connect with faith-based organizations and really understand, what do we have to do in order to prevent this in the future? So there's a lot of strategic planning that's going on so that we can think about the problem from a systems perspective while we're trying to, develop messaging as the landscape changes every day. Because there are other components, I think, to, addressing the challenge beyond just communication, beyond just access. There are all these other factors that are at play across the social determinants of health, across different systems, across different, types of professionals who really have a role in making sure that this never happens again.
I want to go back to something that Breanna said a minute ago and ask you, Colleen, to what degree has explaining how the vaccines came to be, has that been something that you find yourself going over a lot with people? Are you also discussing clinical trial structure?
Yes, absolutely. And I feel like in anticipation of one of the questions we might answer later, that I have really enjoyed the learning for myself. I think in engaging and listening to what people are concerned about and looking things up for myself and being asked for has been one of the most rewarding things in a difficult year, to feel like you're sort of trying to be a source of truth and trying to be a source of balance. And I think that's one of the things that, again, I'm really counting on Brittaney to help us fix in the future, which is public health communication. Mm-hmm. And one of the things I talk about is source of truth. I now have a cadre of a lot of people that we talk about vaccines, even though after we've gotten it. So I like to kind of go check and do my rounds and say hi to people. And, in the mailroom in our hospital, I've got two lovely ladies who I help facilitate them getting their vaccines. And so their first question every time they see me, like, Dr. Kraft, all right, D down the hall says we're about to get 3 shots because we don't have. I said, okay, who's your source of truth here? Is D down the hall a source of truth? So they want to use me as a source of truth, which is good, but I'm also really excited to try to empower people to be resourceful about finding their own knowledge, and also remembering that you can find all sorts of crazy things in this onslaught of social media. I mean, we didn't have this in the 2009 pandemic H1N1, plus we already had sort of the beginnings of a lot of different things. So it's just a different time. And then I think the social media and the communication stuff is so confusing to people. So I talk a lot about D down the hall. I'm gonna have to someday meet D down the hall. Keep forgetting to ask who D down the hall is. But I just think it's been, for me, it's been very rewarding because it's intertwined with those relationships. And I'd honestly rather answer their questions all day long than some of the stuff I get that's, you can imagine, on my text messages from people I haven't talked to in years, decades, asking me all sorts of things. But there's something rewarding about having that dialogue, and that they want to talk about it. I mean, they've already been vaccinated, but they want to kind of keep pushing their knowledge, and that's really exciting to me.
The writer Emily Willingham, who spoke at Emory last semester, coined a phrase probably about 10 years ago in one of her pieces, the nerd node. And what she meant was like, who is the person who's the nerd node for your personal network? For science writers, it usually is us, right? They're the person that people come to in the family or at parties or something like that with questions. And it sounds like D is one of your nerd nodes. But you raised a really important point, Colleen, I think, which is that when I think about the timelines, this really is sort of the first social media pandemic. I mean, Facebook and Twitter were founded in 2006. We didn't have the first iPhone until 2007. So both the platforms and the tools by which we are circulating the information in social networks had only really started to get going in the 2009 H1N1 flu. They were certainly very active in Ebola in 2014, but that was much more regionally contained. In this case, it really is, millions of people all engaging at incredible speed with this exchange of information and misinformation and disinformation. And that's what I want to ask you all about next is to what degree you're encountering or you're hearing from patients or clients or research subjects, how much of a problem or misinformation, and here I'm making the distinction between misinformation is sort of well-intentioned and disinformation is deliberately weaponized, how much of a problem that is for people's understanding of what the vaccines are about and what they're going to do. Risa, let's circle back around to you.
Sure. So actually, that was one of the things that we wanted to look at was the effect that misinformation might have, information that wasn't really accurate. And we did have IRB approval, and we did actually provide the correct information to people at the end of the survey. But providing some less than accurate information had amazingly strong effects on people's ideas. When for example, again, remember I had said at the beginning that one of the most important thing that we found was that if people believe everybody else is doing it, they are more anxious to get the vaccine. When we said to people that there was a huge reluctance to get the vaccine, and by the way, that is said in the news, that had a very large negative effect on people yeah, well, maybe I don't need to get the vaccine either. Saying it was safe didn't do very much. We also, there's some suspicion that the government is really trying to get us all to have identification cards, the little vaccine cards that say, I had the 2 vaccinations, but have identification cards. And to some people, that sounds very threatening. When we put that one out, that also didn't have much of an effect on people. But the idea that people weren't taking the vaccine, other people were not getting it, had a very major effect. Then when you think about it, it's not just people exchanging ideas on Twitter or Facebook, but so the media, the number of media sources, the number of online news sources or newspapers or sources of information has exploded to the extent that it's very difficult for people to sort between one thing and another. And there are huge, huge numbers of conspiracy theories that you could find if you go on the internet right this instant, even though it is said that Facebook and others have taken them off. So it's out there and it is affecting people.
I saw a piece of research yesterday from a research group that started studying misinformation on Twitter pretty much at the start of the pandemic. I mean, we are now, this week, we are 1 year plus 1 week since the pandemic was officially declared. In March last year, they identified 46,000 misinformative Twitter posts a day. And that was just when things were just getting started. Just imagine how many millions of people are being exposed to millions of pieces of bad information now. For the rest of you, either in your practice in dealing with patients or in fielding people's questions, how much of a role is misinformation playing and how are you combating it? Breanna, do you want to talk about that?
Sure. I think one of the challenges with social media is it's catered to fit your preferences, right? So the more things you like and who you follow, you can create like very much a bubble that reinforces the ideas that you already wanted to believe in. And so I think that people can really create kind of an isolation where even if they might be more open to other messages, they're simply not getting through. So I think that's where, the idea of just one of the things we encourage like our staff to do was just post their own vaccine experiences, like unfiltered. We like took pictures, and we had one of our staff members like offer a picture to anybody and recommended like, here's different things you can say, but just be you, like post to your family and friends. And for some of our staff members, you can tell the difference. Like my Facebook feed was all like, I'm so happy you finally got this. This is great. Can't wait to get mine. But I had staff members come to me the next day and say like, I had to shut it off. Like I was getting so much negative feedback or questions. And it was just a reminder to me of also just the power of even those posts that maybe a staff member posts something and got some negative feedback, but in her feed or his feed, there might have been people that said, oh, this is good. This is the first person I know that's been vaccinated. And that I think often it's those types of like little changes in those relational moments where people who might not be convinced by other avenues in their life, that personal connection leads them to seek other sources of information. So that's been interesting. I don't necessarily always talk to my patients about like social media versus where they have ideas, more just hearing the concern and creating a space to discuss it. But it's been interesting to just watch, even within the staff, the people I speak to daily, how their experience has been as they've told their own vaccination story.
So Brittaney, the work you do is very much operating at the level of the community. So what's your perception of the circulation of misinformation really down at the community and family level? And how do you intervene or help people to break the cycle of listening to stuff that may not be good for them?
Yeah, absolutely. So the focus groups that we've actually been leading in the community, misinformation has certainly been a theme that has arose. The one that I can remember that has come up has been, the misperception that the vaccine may alter one's DNA. I think ultimately what we try to do is very similar to what others have mentioned in terms of making sure to listen to what the misperception is, but to correct the misperception before that interaction is complete. So before the focus group is done, or if it's in a survey, we would be showing individuals what the correct information is after assessing where their misperception lies. So that's one strategy. The other is actually making sure that we are keeping a pulse on not just emerging technologies, but emerging social media as well. So one of the popular platforms that really had buzz around the December-January period was Clubhouse. And easily we learned that there was actually all of these different Clubhouse rooms that were being stood up from individuals who didn't have medical backgrounds, from individuals who were spreading misinformation, or they were providing a platform for people to spread the information. And so as a communication strategist who, works in practice, but then also our team of communication strategists who are more on the research side, we have to kind of come together to develop an approach for how do we intervene. So that means maybe we should be on Clubhouse. Maybe we should be joining some of these meeting rooms so that we can be that voice to intervene. And ultimately, it's about ensuring that, our partnerships are diverse as well. So it helps us think about how do we work outside of the box. How do we work outside of academia? How do we work outside of the clinical facility to actually engage with the organizations who have the attention of our audience, right? How do we partner with them? So that's one approach. And I think that's the work that we're still, going through every single day, is just trying to understand what are the emerging trends, because we have to be not too far behind.
So does that mean you've had to think up strategies for Instagram and TikTok and Snapchat and memes and so forth as well?
It depends. So we're not at that stage of our campaign yet. We're actually still in the formative research. And so when we are able to gather the insights of the preferred communication channels that people have based on their age range, based on their race and ethnicity, as well as based on whether they're in a urban or rural area, and learning disabilities, we factor all of that information into where should we then go and target those individuals based on where they already are. So those insights will keep coming. Right now, we've finished focus groups with the African-American community, as well as the Latino community, and the other groups will follow. And then at that point, we will have the tailored plans for how to reach each one of them.
That's amazing. That it has to be, I mean, that makes sense, but that it has to be so granular. On the one hand, that's fantastic. On the other, it sounds like so much work.
Yes, it is a lot of work, and it's time consuming work. I think that that's, where we are too, is understanding that this is a very pressing, community concern. We don't have a lot of time. And so how do you go about this community-based approach and gathering those insights so that we can do the work right? But then also, how do we do it at the speed that's needed? We're a year into the pandemic. So how do we apply those insights quickly in a way that can have real impact?
I want to slide sideways a little bit from misinformation to sort of patient concerns and start wrapping in some of the things that people are saying back to us in the chat and the Q&A. So one person has asked about her vaccine reaction, that she got her first shot and she had a really sore arm. So Colleen, could you talk a little bit about the reality that there are some side effects to the vaccines, even if they're transient, and how you talk to people about how that's something that they should expect and not be worried about?
Yes, I think this is something that I've actually learned the most about during this time, is thinking about side effects as only negative. And so I think something that I've learned is when we're trying to stimulate our immune system to fight something, it's going to make us feel bad. And so I think this is one of the things that for years as an infectious disease doctor, about answering the I got flu from the flu vaccine, what I think I've observed and learned so much during this vaccine rollout is that our immune system is part of why we feel bad when we're fighting an illness. And it's not that like earth-shattering of knowledge, but when we realize that the vaccine or the component is making us feel that way because that's what we would feel like if we actually got the disease. But by the way, isn't it great that we don't have the disease? We're making, we're lining up our guard against that disease. And so I think that's something that I have really thought so much about and so deeply when we think about the different side effects. And I'm going to just confess, I was like a super big baby after my first vaccine, big baby. And then my second one wasn't as bad, and everybody has their sort of little story about what's happened. So, I don't know if this individual had any worse symptoms, but a sore arm in 1 hour, I think just means, things are working and they're moving.
So the thing that's fascinating to me about this, as as a journalist and somebody interested in narrative, is the degree to which the personal storytelling is so important in reaching people. One of the fascinations for me over the past year was watching, after the kind of the first emergency of the pandemic passed, how people stepped forward in varieties of social media, many of them healthcare workers, to post long Twitter narratives of what their experiences were like treating COVID patients, dealing with the press of illness, being scared for their own families, going home exhausted at the end of the day. One of the most magical storytellers for this is Dr. Kimberly Manning at Emory's Grady Hospital, who posts these fantastic long Twitter narratives about speaking to her elderly patients, about convincing them that that the vaccine is safe. And she tells them her own story as an African-American woman and doctor of getting the vaccine. And you can see that they are listening to her, and it's just magical to me. It's fantastic. There's a question I'm going to have one sort of final question when we end the hour, but I want first to turn to something that several people have asked about and that I think is really important to the folks who are listening to us. And that is, how do we make the vaccine rollout equitable? And how do we express to people what equity is? Breanna, you were talking a few minutes ago about how your patients have a lot of confusion about, who's qualified for the vaccine. Are they protected? What if someone in their hospital, in their household hasn't qualified yet? And I really want to ask each of you, so I'll go around the room, what your thoughts are about how we've done this, who we've prioritized, who are we leaving out, and either could we have done this differently, or what should we be doing from this point? Colleen, let me start with you.
Sure. So I think that we have made this sort of a technological rollout as well. And I think that that's hard. My elderly neighbor, I had to sign her up. She doesn't have internet. She doesn't have an email account. And so we are not reaching all the populations. And again, really thankful for Risa and Brittaney for their research that sort of helps us, like, sort of in a more objective and bigger picture, figure this out. But we really, I would love to see this roll out. My grandmother moved in with my parents during the pandemic, and my parents happen to be here because they're both vaccinated, and I'm so excited. I can hardly stand it. But they, like hospice and how hospice rolls out, it meets the needs of the individuals. And I don't know enough about the economics of hospice, but I would love to see that type of support in the vaccine rollout, where there's not Googling all these different websites and trying to figure out how to get it. And, some people can game the system because they know how to game the system. It would just be nice if, we used our data and there was an organized, rollout where people are sort of handed or mailed or, in a very clear way what to do next. And I think what we're seeing is that people that know how to use technology are the ones that are first in line. Mm-hmm. And that's not necessarily a bad thing because there's some efficiency. And Brianna's experience at Good Samaritan also would show a lot about that you can do these things all different ways. But I think, just looking at the healthcare system to, again, my very narrow perspective is that people that are good at computers or figuring things out or have time or have resources to figure it out that can drive 5 hours, that can drive 3 hours, it's favoring those people. Whether or not that's equitable or not, that I don't think it is, because you're still like biasing towards one group of population. But that's my perspective.
So Breanna, Colleen tagged you, so I'll go to you next. You have a patient population who in many cases are marginalized. They have problems of access. Just as society as a whole, there are systems that exclude them. Would you have wanted to see the vaccine rollout go differently? Can you imagine a way in which it would have been more equitable if it were organized differently?
Yes, definitely. I think first, when I think of equity, I think that the interventions and the programs and the resources need to match the needs of the individual, the community, which simply means like a one size fits all approach is not equity, right? And so I think at a very base, what the question was is we can look at the data, because we have good data on who is dying of COVID, who is most at risk for COVID, and that we would have matched the vaccine rollout to prioritize those people. And in theory, we did a little, right? Like we said, like, okay, healthcare workers, like they're really exposed, they should get vaccinated. And we said, the elderly are dying. But if you look at the data that, those trends and ages aren't the same across different race and ethnicity data. The other problem with like Georgia, for example, our vaccine rollout is we've bypassed essential workers. And just to make it really personal, I have, my husband is a public school teacher who's teaching back in the classroom. So obviously for my family, it was like a personal benefit when teachers got pushed up. And absolutely, I think teachers need to be vaccinated, especially before they were back in classrooms. But like, who didn't ever get pushed up, who there was no lobby or like Facebook posts or like everyone sent emails, were like my patients in meat packaging plants, my patients in grocery stores, my patients in cleaning services, that for most of this pandemic, my husband as a teacher stayed home and taught from a computer. And none of my patients stayed home. The vast majority of my patients were in professions that were essential and never got to decrease their risk. but they're still not in line for vaccination unless they now have a chronic condition. And fortunately, with the chronic condition list, I can now get a lot of those people in, but it shouldn't have had to be that way. I should have been able to prioritize them because for a year, they bore the risk and they had the highest death rates, and they were never prioritized. And we could have done that. And then I think another example of that too is just in like where are vaccine sites located? And NPR did a piece that early vaccine sites left large deserts in areas that were predominantly communities of color. That's improved some with time, but we're still not there yet. That, you know, we could have also looked geographically, or where are pockets that have been hit really hard, what hospital regions have higher death rates, and are we making sure that vaccines get to those communities? And so I think it is an ongoing question of equity that we've seen throughout this pandemic, is that as we have a tool and we have solutions that help people survive and help people avoid infection, how are we matching that to the needs? And I think that's a real challenge.
Those are such great remarks. Thank you. Risa, what does your research tell you about how the vaccine rollout was perceived? Did you get any feedback? Was that a thing that you asked people about who should be prioritized and who is?
We didn't, but I just want to add to the excellent comments that we just had, and that is, it's interesting that this has all been done by states, and then even by states, the notion of where in the state is the vaccine. So it's true, people who were on computers, I had one shot in Cumming and the other shot in Macon. I live in Sandy Springs. Yeah. And I suspect that there are areas that have supplies of vaccines that are not being taken advantage of. And then, of course, in the metro area, there's not enough vaccine. And it's been a very, very strange process. But we did not ask our survey, our respondents about the rollout, no.
So one of the things I do is that I am a contributor to Wired magazine, where I've been writing about the pandemic and its intersection with the public health system. And a couple of months ago, I remember writing a story about how, because we have legally a state-based public health system, things were going to look different state to state. Every state would get to make their own decisions. And if you happen to live close to a state border, you might be getting a vaccine or waiting for a vaccine there. Say your state might say, we're going to do it all in the county fairgrounds. And you'd be able to look across the state border and see people in the state next to you walking up to their local pharmacy. And I remember talking to experts in the public health system saying, isn't this going to create confusion? And they said, oh, yes, it will. But we can only control what happens within our own state and try to judge what's best for our state's population. Even if the other state population is only 10 miles away, they are outside our responsibility. It's been really interesting to see that some states actually kind of allowed their borders to be porous, and that you can drive to Alabama, or people can drive from North Carolina into Georgia and actually get their shots here. It's great that people are flexible. We're just about the end of our hour. I'm sorry that we have lost Brittaney, because I really wanted to hear what she had to say about this. So here is my final question. I'm going to come back, take moderator's privilege and pose the final one myself. And that is, we still have people listening. Yay. What would you like the people who have been engaging with us this evening to take away from this conversation about perceptions about the vaccine, about concerns about the vaccine, about pushing back against misinformation or vaccine hesitancy? What would be your counsel to them, and what would you wish for them to do to try to contribute to our becoming immune to this disease as a society? Risa, I'll start with you.
Well, I would say that in this topic, as in some other topics, it's important not to avoid the conversation. Sometimes it's difficult to have difficult conversations where people are going to disagree because they're coming from a different point of view. But we do have influence on our relatives and our friends, and it's important to engage in this conversation because it's such an important one. That's my takeaway.
Thank you. Breanna, how about you?
I agree. I think sharing your story, especially if you had questions or doubts, like express what those were and how you sought information and what was your journey to vaccination and what it felt like. And I think that storytelling and that truth telling, it really encourages those people that trust your insight. And I think my second point is that you can express complete confidence and enthusiasm for the vaccine and still question and speak out against the inequities in the system. And we need to do both, and both are correct.
Colleen, as a physician, I will let you take us out. What are your, oh wait, no, Brittany's back. Yeah. Yay, fantastic. So we'll go to Colleen, we'll give Brittaney a moment to get reconnected. But the question is, what is the one message that you would like the audience who've been listening to us to take away tonight, or what are the actions you would ask for from them? Colleen, how about you?
I think what Risa and Breanna have already said are number 1 and 2, but I will also say, and I love that Risa's work supported this, that I promise you that having COVID itself is and can be far worse than this vaccine.
Brittaney, thank you so much for working so hard to get back into this conversation.
Yes, thank you.
I really appreciate it. So we are at the point where I'm asking everybody sort of for their final comments, and what I'm hoping to elicit is for the people who've been listening to us tonight, what is it that you would like them to take away from this conversation? And if there's an action that you would ask for from them, what would that be?
Oh, absolutely. So, we're really focused on the message, spread facts, not germs. And actually, if you visit spreadfacts.germs.com, you'll find our website. And it's really focused on those preventative measures that we've been talking about from the very beginning, is even if you're not ready to take the vaccine just yet, to continue to wear your mask, to wash your hands frequently, and to social distance. And then the second thing is just to stay informed. So to find a credible source that really has information that can be trusted, so that you can spread the facts about the vaccine as opposed to any misinformation.
That is such an awesome saying, and that you have the URL for that is amazing. Well, thank you, the 4 of you, so much for sharing your thoughts so candidly, for being so informative. It has just been an amazing conversation, and I hope that it benefited the audience, and I hope many more people watch it on replay. So Dr. Risa Palm of Georgia State University, Dr. Breanna Lathrop of the Good Samaritan Health Center, Ms. Bethea of Morehouse University School of Medicine, and Dr. Colleen Kraft of Emory University School of Medicine. Thank you so much. I'm Maryn McKenna, journalist, author, and from Emory College's Center for the Study of Human Health. On behalf of the Atlanta Science Festival, thank you all so much.